Good morning, everyone. I am Dr. M.I. Mohammad Suja, lecturer in Department of Physiology. Today's lecture topic is on circulation through special organs. So we'll be looking into the cerebral circulation, coronary circulation, renal circulation, cutaneous circulation, and portal circulation. Cerebral circulation is mainly blood supply to the brain via four arteries, two internal carotid arteries and two vertebral arteries. They form circle of Willis and give rise to six large arteries: anterior cerebral artery, anterior communicating artery, internal carotid artery. The area colored in the circular fashion is the circle of Willis. And the blood supply is drained by deep veins and dural sinuses. Then it goes to the sigmoid sinuses. Then it enters into internal jugular vein. Then it enters into the right atrium, then right ventricle. Then it goes on. But the small amount goes through pterygoid plexus, emissary veins of the scalp, and paravertebral veins. The features of cerebral blood vessels are it has a tight junction between endothelial cells, and we call it blood-brain barrier. The astrocytes is surround the capillaries like this. If you have a look at this, this is your lumen of the blood vessel. These are endothelial cells. They are very tightly bound together with the tight junction. And outside of the blood vessels are neurons, astrocytes. So like this. This is the endothelial tight junction barrier. This is your blood. This is your astrocyte. This prevent or limit the passage of substance from blood vessels into the brain tissue. Sorry. Cerebral blood flow is 54 milliliter per 100 gram of brain tissue per minute. So total about 750 milliliter per minute, because the brain weighs 1400 grams. 15% of the cardiac output is supplied to the brain. But the changes in regional blood flow may depend with the neural activity, but the total blood flow remains relatively constant. That means if 750 ml of blood goes to the brain, so 500 may goes to cerebellum, 250 may go to cortex. In other instance, 750 will go to brain, but cerebral cortex may get 400. Depends on the activity, the neural activity, the blood supply or the regional blood supply varies within the brain, but the cerebral blood flow is constant, relatively constant. There are few factors regulating cerebral blood flow. Intracranial pressure, that means that is the pressure inside the skull. So inside the skull or your cranium, you have brain tissue, spinal fluid, and blood in the blood vessel. So all three contributes to the intracerebral pressure. Another factor is viscosity of the blood, cerebral arterial and venous pressure, and the degree of active contraction or dilatation of the cerebral arterioles. So this is just a overview. If you take this cranium, you will have intracranial pressure inside this. You have the brain tissue, spinal fluid, and the blood in the blood vessel. These are cerebral arterioles and cerebral veins. You should know the factors which affecting the or regulating the cerebral blood flow and how it's affected. The role of intracranial pressure. Cranial cavity is a confined space. It is made of skull, that is bone. It cannot swell up. So it is confined. It contains the whole brain, 1400 grams of brain, almost 75 milliliter of blood, and the 75 milliliter of spinal fluid. When the intracranial pressure is increases, the cerebral blood vessels are compressed. So the blood flow which comes to the brain is reduced. Any change in venous pressure would cause a similar change in intracranial pressure. If venous pressure is rises, then cerebral blood flow is decreasing. So the effective cerebral perfusion gets decreases. This is explained by the Monro-Kelly doctrine hypothesis. The Monro-Kelly doctrine hypothesis explains the sum of volumes of brain, CSF, and intracranial blood is constant. It cannot be changed. But an increase in one factor should cause a decrease in one or both of the remaining two. Imagine the brain volume is increased due to any brain tumor, excessive proliferation of tumor. So the brain space, the confined space is get more tissue. So it should be, the occupied space should be compensated by reduction in the either CSF or intracranial blood. That's what said by Monro-Kelly doctrine. So like this, the normal brain, here the brain tissue, venous arterial blood, and CSF. These are just a diagrammatic graph. It not exactly resembles the amount of the area occupied by each component. Okay. If there is a brain edema, the brain tissue is increases, the water is increases, so it increases the intracranial pressure. So the blood and CSF are reduced up to a certain limit, because we need cerebral spinal fluid and blood for the supply of the brain. So if we are losing too much of blood, and it causes problem. If the brain tissue is occupied with the tumor, and the tumor is pushing the normal brain, so the brain is herniated through the spinal cord area, so it compresses the centers in the brain, it can cause death. If a person accelerates upwards, when someone is accelerating upwards, like when you are taking off an aeroplane or just going upward too fastly in the merry-go-round or something, blood tends to pool in the legs due to the gravity. So it reduces the arterial blood pressure at the head. So when the arterial blood pressure is reduced, the central venous pressure also reduces. Blood is one of the factors determine the intracerebral or intracranial pressure. So when the blood pressure is reduced, your intracranial pressure also reduces. This causes less compression of the cerebral arteries which are found inside your brain. So, even though the pressure at the arterial end is reduced due to the less compression of the cerebral arteries, the blood can flows into the brain. It can maintain the cerebral blood flow. So your brain will get enough oxygen. Hope you understood this. If any fail in this mechanism will lead to faintishness or blackout. Like other way, when the downward acceleration occurs, you have to work it out and remember both the two extreme of one string. You have to remember what happens when you accelerate upwards, when you accelerate downward. So the auto-regulation of the cerebral blood flow. What is auto-regulation? Auto-regulation means the ability of any organ to maintain relatively constant blood flow to that particular organ despite changes in the perfusion pressure. When it comes to brain, the ability of the brain to maintain relatively constant blood flow despite changes in the perfusion pressure. So autoregulation occurs between 65 to 140 millimeter mercury pressure because your brain is one of the vital organs. It needs blood supply or the oxygen supply constantly, continuously. When there is a reduction in the blood pressure, if the blood supply to your brain is reduced, the brain death can happen. So, body itself has its natural phenomenon to maintain or to keep the blood flow constant. But that autoregulation happens within a range of blood pressure. The blood pressure is beyond the range, then the blood flow is depend on pressure. It's pressure dependent. Within this range, because of the autoregulation, even the blood pressure is reduced or increased, the blood vessel adjust themselves to supply a constant blood flow to the brain. Know the concept and know the autoregulation range. There are metabolic factors which affects cerebral blood flow. When there is an increase in carbon dioxide and hydrogen ion, there is a cerebral vasodilation occurs. So when there is a hypercapnia, your cerebral blood flow is increases. They say 70% in carbon dioxide, that means increase, it doubles the cerebral blood flow. So when carbon dioxide level is increased by 70%, your cerebral blood flow doubles. Oxygen. Oxygen also has a impact on that. That is a narrow impact. Because in the low oxygen level, cerebral vasodilation occurs. So vasodilation will result in further reduction of the oxygen. So you know this graph. This is the normal cerebral autoregulation curve. With the increasement of the pressure, the cerebral blood flow is increases, but within the range, even though you increase that means the mean arterial pressure, this pressure, the cerebral blood flow will not change because the autoregulation is active. But when the blood pressure limit reaches autoregulation limit, what will happen? The cerebral blood flow further increases. But this is not good. You know why? Your cranium is a confined space. So when too much of blood pressure, too much of blood goes inside your cranium, so according to the hypothesis of doctrine, what will happen when the too much of blood goes into that space? It tends to push on other two factors, brain tissue or CSF fluid, because it has to maintain the cranial confined space in a constant amount. So that will affect your brain function. In increase partial pressure of carbon dioxide, to wash out the carbon dioxide, the cerebral blood flow is increased because the major molecule or major substance of brain energy production is glucose. So when you have increased carbon dioxide, that means glucose amount is low. So the blood vessels are vasodilated, and the blood supply increases, try to get more oxygen to the brain. So tell me, what is the major energy substance of heart? You have to find it out. That is one of the true false MCQ. So and when it comes to partial pressure of oxygen, when the oxygen level is high, it will cause vasodilation. When the oxygen level is coming down within certain level, it maintains cerebral blood flow in a constant level. Like this, within 35 to 40 millimeter mercury, the cerebral blood flow is fine. When the cerebral partial pressure of oxygen falls below 20 because of less oxygen, the brain function get damaged and it will lead to coma and eventually death. There are few substances released from astrocytes also changes the regional blood flow. Now we'll have a look at Cushing reflex. When there is an increase in intracranial pressure because of the increase in the confined space, the cerebral blood flow or the cerebral perfusion pressure is reduced. It will cause cerebral ischemia. When there is a cerebral ischemia or the blood supply to the brain is reduced, your body tends to send more blood to the brain in point of surviving blood tissue. So your body has to pump more blood. That means your heart is pumping more blood. So the systemic blood pressure is increases because your systemic blood pressure has to overcome intracranial pressure, which is opposing this to supply enough blood to the brain. When there is a systemic blood pressure increase, what will happen to your baroreceptor? The baroreceptors are getting activated. I think by now you know the baroreceptor mechanism very clearly than me. So when the baroreceptor reflex are stimulated because of the increased blood pressure, ultimately heart rate comes down. So bradycardia and hypertension. Just check it out. There are only one D for the bradycardia. Typing mistake. So bradycardia and hypertension simultaneously occur. That we call Cushing reflex. That means, in a nutshell, because of the increase in intracranial pressure, the cerebral blood flow is reduced. That leads to increase in systemic blood pressure that activates your baroreceptors and it causes reduction in the heart rate. So bradycardia and hypertension, that we call Cushing reflex. Sorry, I have a bad cough. So we expect you to know this. This is one of the very important area. You may get assessed in the exam. And just go through this is a explanation of what I have mentioned. Then we come to the coronary circulation, that is blood supply of your heart. From your anatomy, you know the blood supply of the heart turn out right coronary artery, left coronary artery. Left coronary artery divides into two branches, left circumflex artery and left ascending artery. So this anatomy is the blood supply. And the venous drainage of the heart, it mainly through the coronary sinus and anterior cardiac veins drain into the right atrium. Other vessels directly drain into the heart chamber, while arterioluminal vessels and arteriosinusoidal vessels are responsible for that mismatch. When it comes to the coronary blood flow, your heart is contracting during systole, relaxing during diastole. When the contraction occurs, the blood vessels which supply the heart also get contracted. So the blood supply to the particular heart area may get reduced or disturbed. Subendocardial region of the left ventricle is affected during systole. Other parts are not affected during systole and diastole. If you look at this graph, see, this is the aortic pressure, this is the ventricular systole. During that left coronary artery, the blood flow is reduced. Because normal coronary blood pressure is 100 to 120, but here during systole it comes to 14. So that means during systole the blood supply to the ventricle area is reduced, but during diastole it's maintained, mainly the left ventricle. The right coronary supplies the other part, it's not affected by systole. So you should know left ventricular part of the heart is getting affected during systole, not other areas of the brain. So there are variation in coronary blood flow. At rest, your heart extracts about 70 to 80% of the oxygen delivered to the heart by blood. So therefore, if we want to increase further oxygen consumption, the extraction is almost maximum. So what you have to do? You have to increase your coronary blood flow. You have to send the more blood to the heart because the extraction is at its level best. When the metabolism of the myocardium increases because of the metabolites, there's the vasodilation of the coronary blood vessel. So it increases the caliber of the coronary blood vessel. So the diameter is increases, the more blood goes into the heart. That we call metabolic theory of autoregulation. There are factors affecting the coronary blood flow. Like I said, there are metabolic factors which causes vasodilation. The factors are lack of oxygen, increased local concentration of carbon dioxide, hydrogen ion, potassium ion, lactate, prostaglandin, and adenosine. But even though all of these factors vasodilate the coronary blood vessel, the maximum effect is by hypoxia. Hypoxia is having the maximum vasodilatory effect on your blood vessels. So this is not the heart sign, this is a blood vessel circle. Hypoxia, the blood vessel size is increased. There are neural factors affecting the coronary blood flow. It's, the adrenergic receptors, the sympathetic flow, alpha adrenergic receptors, vasoconstrict, beta vasodilate. But remember very carefully, you may think when there is sympathetic activity, there's a vasoconstriction, so blood supply to the heart is reduced. But when there is sympathetic activity, we need more blood. So listen very carefully. The direct effect of noradrenaline on coronary blood vessel is vasoconstriction. But due to its inotropic and chronotropic effects, myocardial metabolism may increase, causing vasodilation due to accumulation of metabolites. What they say is it, the vasodilation happens due to the metabolites is more than the vasoconstriction by the alpha adrenergic effect. And stimulation of the vagal fibers also dilates your coronary. Few coronary artery diseases like angina or MI can be due to the reduction in the coronary blood flow. Then we come to renal blood flow. It is almost 22% of the cardiac output. Compared to the weight of the kidney, high blood flow. The blood flow indirectly determines GFR, so it modifies the rate of water and solute reabsorption at the proximal convoluted tubule. It participates in the concentration and dilution of urine. If you get less renal blood flow, your urine is concentrated. If the renal blood flow is more, the urine is diluted. Per gram kidney, your oxygen use is 2 times higher than other organs. It has a 7 times higher blood flow. High oxygen demand is mainly for the sodium reabsorption at your nephron level. So when there's a high GFR, there's a high sodium reabsorption, more oxygen is needed. Don't worry about the terms of the GFR reabsorption. We'll be dealing that in depth in your renal physiology. Just know the percentage of renal blood flow is 22%. When there is a more blood flow, more GFR, then the more sodium reabsorption. We need more oxygen for that, because the sodium reabsorption is an active process. So determinants of renal blood flow, just know the equation. And the renal blood flow mainly controlled by renal vascular resistance. The vascular resistance is controlled by sympathetic nervous system, hormones, and local mechanics. 98% of the renal blood flow goes to the cortex. There are 2 areas in the kidney, medullary area and the cortical area. So GFR, that is glomerular filtration rate, depends on hydrostatic pressure and colloid osmotic pressure. There are factors increase GFR, there are factors reduce GFR. Strong sympathetic activation, norepinephrine, epinephrine, endothelial constriction of renal vessels, angiotensin II, all decrease GFR. Endothelial-derived nitric oxide, prostaglandin, bradykinin, they increases GFR. Okay, you should just know the factors which increase GFR, which reduces GFR. Autoregulation of renal blood flow is very important because it has to maintain your GFR at constant level. As we see for the cerebral blood flow, there is a zone of autoregulation, and you know what is the normal mean blood pressure for that autoregulation. So when there is a constant renal blood flow during the autoregulation period, your GFR also constant. So there is no reduction or increase in the GFR even though your mean arterial blood pressure is increases within that range. So within that autoregulatory range, even though your renal blood pressure or mean arterial blood pressure is increases, because of the autoregulation, renal blood flow is maintained constantly. When it is maintained constantly, your glomerular filtration rate is maintained. Autoregulation range for renal is 90 to 180 millimeter mercury. So there are pressure sensitive myogenic mechanism, sodium chloride concentration dependent mechanism, both contribute for the autoregulation. This is just a cross section of the Bowman capsule and proximal tubule area. Don't afraid or get confused of this. This is just a diagram. We will be dealing in detail in renal physiology. So, autoregulation is absent below arterial pressure of 90 millimeter mercury. Autoregulation is not perfect. Despite autoregulation, renal blood flow and GFR can be changed under appropriate condition by several hormones. So there are few factors which cause vasodilation, stretch, histamine, bradykinin, acetylcholine, nitric oxide, and you just go through the diagram to know what causes vasoconstriction, what causes vasodilation. The tubular glomerular feedback. Single nephron glomerular filtration rate is greater in juxtamedullary nephrons. It's around 50 nanoliter per minute. Other nephrons is 30 nanoliter per minute. This is mainly determined by the composition of the fluid in the distal nephron that we call tubular glomerular feedback. Just know that the feedback is called tubular glomerular feedback. We will learn that in future. Then cutaneous blood supply, circulation, the blood supply for the skin. The primary role of cutaneous circulation is to regulate heat transfer. The blood flow in response to thermoregulation can vary from 1 milliliter to 150 milliliter per 100 grams. Okay. This wide range is achieved by shunting blood through arteriovenous system. So the arterioles of the skin have a high density for alpha-1 adrenergic receptors. The bradykinin mediates arterial dilatation in the skin. There are venous plexus. It acts as a blood reservoir for that. It contains the greatest amount of cutaneous blood at a given time. And the regulation. Increased sympathetic nervous system activity can cause vasoconstriction and reduction of heat loss. The exact opposite occurs when activity is reduced. Okay, the local movement can produce vasodilation and increase local blood flow. The local cooling can cause vasodilation. The GABA responses are controlled by central brain temperature. Usually, the cold is known to cause vasoconstriction, but when there is a severe cold temperature, the vasodilation occurs due to the paralysis of the muscle vessel. This we call cold-induced vasodilation. The extreme of physical compression like long anemia leading to metabolite accumulation can cause reactive hyperemia. You should know what is reactive hyperemia. And epinephrine, angiotensin 2, and vasopressin cause vasoconstriction. Skin plays a major role in blood pressure regulation. So, in hypertension, the sympathetic system is activated due to reduction of the blood pressure. This causes cutaneous vasoconstriction and increase in the total circulation. So, it causes shift of the cutaneous blood to the so the venous return is increases. Causes the cardiac output. The blood pressure is going up. So there are two reactions: white reaction and hyperemic reaction. White reaction is if you have a pen or a sharp thing and you just draw a line like this, you will get a line, then it becomes pale. Okay, you just draw a line. A blunt object, you get a line formation. That is called due to the contraction of precapillary sphincter, draining blood out of the capillaries and veins. But it is not permanent. It only lasts for 10 to 15 seconds, then it disappears. That is white reaction. Then we come to the final circulation, that is portal circulation. The liver gets approximately 20 to 30% of cardiac output. It gets applied from portal 5% and hepatic 25% of the half of oxygen demand is met by hepatic, even though it is 25% by the hepatic artery. The hepatic portal system connects to the capillaries of the gastrointestinal tract with the capillaries in the liver. So this you can see there's the gastrointestinal system. When there's blood supply, the drainage of blood from these into the liver via portal vein, it goes through the liver to the urina. So when we eat something, any toxic substances, those are through the portal vein, reabsorbed at the gut level, and goes into the liver where the detoxification occurs and the pure flow reaches the inferior vena cava, it empties into the cardiac chamber. The circulation of nutrient-rich blood between the gut and the liver is called portal circulation. Removal of harmful substances that are digested occurs in the liver via this system. So these are the tributaries or tributaries for the portal veins. So see, the whole of the gastrointestinal system is drained to portal vein. Splenic vein, inferior mesenteric, middle colic, ideal trunk, superior right colic, right gastroepiploid, everything is drained into the portal vein. Then other thing is called anatomy. You will be studying this in detail in anatomy, but just know what is it. It is the collateral connection between systemic and portal veins. So why you need portocaval anastomosis? To provide an alternative route of circulation when there is a blockage in the liver or portal vein. Because everything goes through the liver. If there is a block, then you cannot supply the blood. To prevent that, we have the alternative route that we call portocaval anastomosis. There's a collateral connection between systemic veins and portal veins. There are major six areas at the esophagus, hemiesophagus vein, the anal canal, around the umbilicus, the lumbar region. We have this connection. Just go through this. This gives you the places where you get portocaval. Right? Lower esophagus, upper anal canal, umbilical, bare area of the liver, at the patent ductus arteriole is the triangle, in the retroperitoneal area. You should remember this chart. The main organs, the weight of those, the blood flow, the oxygen consumption, the percentage of the total cardiac output. If we ask total cardiac output for the liver is 27.8%. That statement is true. Like that, from this chart, we can create 100 of MCQ. So we should know it in if that we came to the end of the section, we have as normally you don't ask question in the lecture. I think all of you understood everything because all of you are brilliant, excellent student of us. And as I always say, may peace be upon you all and have a nice day. Thank you very much.